Good day to everyone. My name is C.V. Mamaril, and on behalf of the Systems for Action National Coordinating Center, I'd like to welcome all of you to today's Research in Progress webinar. We do apologize for the late start. We were trying to resolve some technical issues, but we are glad that you're able to join us today. And before we get started, we do want to acknowledge the funding and support of the Robert Johnson Foundation for the Systems for Action National Program. And we are excited today for today's presenters who are part of our new cohort of grantees that are being funded and supported by the Robert Wood Johnson Foundation to undertake research on strategies to achieve alignment, collaboration, and synergy across delivery and financing systems as part of the Systems for Action National Program. So today's presenters on our Research in Progress webinar are linking medical homes to social service systems for Medicaid populations. And during the presentation, I'd like to encourage everyone, if you have any questions, that you can type your questions in the chat box in your screen. And without further ado, I'd like to introduce our presenters and commentary speakers today, beginning with Dr. Sarah Scholle, who is an expert in health services and quality measurement in multiple settings. She has a demonstrated record of moving innovative measurement concepts into implementation, particularly through NCQA's healthcare effectiveness on data and information set. Current measurement projects focus on cross-cutting areas where new health information technology is critical, including behavioral healthcare, patient-reported outcomes, and goal setting and improvement. Her experience also includes projects to test and assess the process of transformation to different models of care, including an initiative to test patient-centered approach to oncology care. She leads NCQA's efforts to expand measures for vulnerable populations. This includes health equity innovation efforts for the CMS Office of Minority Health. Sarah has also led an AHRQ CMS-funded Center of Excellence in Pediatric Quality Measurement, which focused on developing and testing outcome measures for adults in depression using electronic health records data, and currently leads a subsequent project to implement and demonstrate improvement on these measures. Sarah has also led activities in measurement related to patient-centered care and the patient-centered medical home, and contributed to the development and implementation of surveys. Our other presenter is Keri Christensen, who has a Bachelor of Science in Industrial Engineering from the University of Iowa and a Master's of Science in Healthcare Quality and Patient Safety from Northwestern. Keri has spent over 20 years working in the health information technology field and has experience with the Illinois Medicaid managed care population providers, including a previous role as County Care Project Manager at MHN. Keri is currently Director for Research Innovation at NCQA with a focus on measurement of social risk and digital health. Our first commentary speaker will be Sherry Lullies, who has more than 20 years of experience working with complex healthcare systems and health plans in a broad range of areas, including integrated delivery system development, population health management, value-based contracting strategy, and network management. As the President and Executive Director of the Medical Home Network, Cheryl leads a virtually integrated delivery system, which is a catalyst to drive delivery redesign and practice innovation in the safety net. She also serves as CEO of the MHN ACO, which is the first Medicaid ACO in Illinois. Previously, Cheryl served as the Vice President of Network Management for WellCare Health Plans of Illinois, a provider of Medicaid and Medicare HMO products. Prior to that, Cheryl held leadership positions at several academic and community systems in Illinois, Indiana, and New York. And our second commentary speaker will be Sarah Standish, who has over a decade of experience as a senior leader in both the healthcare and non-for-profit sectors. Sarah is passionate about data-informed strategy and operations at the intersection of business and mission to spark sustainable, equitable community development. She developed the Health Leads evaluation strategy, including direct evaluation of the organization's operations at healthcare delivery systems across the county, dissemination of findings and best practices, and support for research and evaluation activities at other institutions and organizations. Additionally, Sarah currently supervises a team she organized at Health Leads that delivers regular performance management reporting to healthcare delivery partners and co-design evaluations. So with that, let me turn it over to our presenters. Sarah and Keri. You have the floor.
Good afternoon. Thanks, everyone. We're really pleased to have this opportunity to talk with you. I'm Sarah Scholle at NCQA, and I just want to say how thankful we are to the Robert Wood Johnson Foundation for the support, and to the team and all of the people in the Systems for Action group for supporting us in this work. We're very excited about this opportunity to try to understand how we can improve the coordination of care between medical care and social services agencies. We know that that this is a challenge for primary care practices, the practices that have taken on NCQA recognition. Some find this to be, something that they do working with a small number of agencies. Some say, this is so hard, we don't even know how to get started. And so we think this work, and especially the demonstration of how to create this connectivity and to support communication is really important and will have a great impact on the field. In this project, we are specifically glad to have the opportunity to work with the Medical Home Network and Cook County on how to think about the question of what does this connectivity support. And so specifically, we want to understand how connecting medical homes and community-based organizations affects whether we can identify social risk, the referrals to social service agencies, whether it improves communication to close the referral loop, and that it actually supports patients with needs at receiving services. So that's our first aim, is to understand that process. And then we also are going to look at what the impact is, because we hypothesize that increasing this communication and improving how we address social risk factors will have a benefit for quality of care and utilize emergency and hospital care. And so those are our aims, the research aims of this work. And I'm going to turn it over to Keri, who's close to the details and has worked with this fine team in the Chicago area to make this project happen.
Great, thanks so much, Sarah. I'm going to briefly go over this slide because Cheryl's going to talk a little bit more about Medical Home Network and the environment that we are evaluating later in the commentary speaking. But to just briefly kind of explain what MHN, what Medical Home Network has been able to accomplish in the Cook County, Chicago area in Illinois. They have a connectivity platform, and it is connected to a variety of different stakeholders, including the health plan, health information exchanges, patient engagement systems. They have an electronic consult system that is helping triage consults across their network. They have several hospitals in the area connected and are performing complex case management between the medical home and the hospitals. But the area that we're interested in is over there on the left-hand side in the red box, connecting those medical homes with their primary care members to community health resources and behavioral health networks, so organizations out in the community that the medical homes can work with to send their patients to get extra services that aren't available at the medical home. Jen, can you advance to the next one, please? I can't see where she is. Thank you. Perfect. Sorry, we're having just a little bit of technical difficulty today. So let's talk about our two research objectives, which are studying the impact of the connection between the medical home and the community-based organizations on the quality of care, and the utilization of services such as emergency and hospital services. Additionally, we are really interested in understanding how that connectivity between the medical homes and community-based organizations is affecting how organizations identify and provide services to those patients. So we're going to use a quasi-experimental design to help us understand those impacts. And we'll talk a little bit about that. First, let's explain who we are. So we've got 3 organizations that are primarily working on this project. NCQA, the National Committee for Quality Assurance, is the primary, and we are leading the quantitative and qualitative research activities and doing the project management. But we have 2 very important partners in Medical Home Network, who are the holders of the data, and we'll talk more about what data is available and how they've been collecting that for the last several years. And they also have the connections to the providers and the patients in their network, both as an ACO and the organizations that they're connected to. And then we have Cook County, both the Cook County Health and Hospital System, as well as the County Care Insurance Organization that the ACO provides services to their members. And they're going to be able to, again, connect us back to those important patients and providers participating in their services, as well as give us access to patient charts that are going to be able to provide historical information. Wonderful. In addition, we've got an advisory committee set up to provide some really important input into all of our planning and as well as our interpretation of our results at the end of the project. And you'll see that these folks represent a variety of organizations from the clinical space, from the social services space, from the patient perspective. We have one of the patients who is served in this system. And you'll notice there we also have Sarah, who will be able to talk at the end of this presentation as a commenter. Great. So let's talk a little bit about that population served. We've provided just some rough statistics, and I think Cheryl will talk a little bit at the end about how the population has changed since we put together the initial proposal. So historically, we've had historically we've had about 150,000 patients that are being served in this system. They are all Medicaid patients because it's a Medicaid managed care organization. And there's no dual eligibles, so they're all under 65 years of age. 65% of them are 18 years and older. Slightly more minorities, a high percentage of Spanish as primary language, and they've got a lot of medical conditions, which leads to a lot of ED visits and a lot of inpatient visits. And as you can see here, the original split of coverage was about 60% of the traditional family health plan, and then about 40% of folks underneath the ACA Medicaid expansion coverage. Additionally, we wanted to say a little bit about the medical homes that are participating in the pilot program. There's 3 primary hospital medical groups, which represent 127 different physician medical homes. And then there's 26 groups that are federally qualified health centers, which is 147 different medical homes there. So let's talk a little bit about where we are in the project. Prior to us even starting the project on January 1st, Medical Home Network and the Cook County system has been collecting data about their patients, both on the clinical side and as far as their social risk factors go, in a standardized way across a large patient population for quite some time. They have been connecting additional hospitals, and they have been doing health risk assessments on all of their patients for quite some time now. You can see we're here in the project. And then this phase that we're particularly interested in, they are going to layer on that connectivity to the community-based organizations. It's not entirely determined yet what all the community-based organizations will be, but we'll get to see that change and grow organically throughout the project. And so you can see that as we're connecting those community-based organizations to the medical homes, we'll continue to be collecting that baseline data, and we will move into collecting the data post-intervention after the connectivity has happened as well. And the way we conceptualized that was using a stepped wedge approach so that we could have the natural experiment that is happening studied. So as medical homes and as community-based organizations come on to using the new functionality, connecting them to each other and providing the patient information to both sides, we will see patients naturally move from the pre-intervention to the post-intervention state. All right, let's talk a little bit about our logic model. We know patients have always had social risks, and we know that we have always connected them to community-based organizations to try to get those needs met. Formalizing the connectivity between the medical homes is going to bring, we hope, 5 increased benefits to the system. One will be clear identification of social risk that's shared amongst the system. We hope that they will be able to better select the appropriate community-based organization to best meet the patient's needs. One of the primary benefits is that the community-based organization will have an increased understanding of the patient's context, being able to see information about their care and their history that they've never had access to before. There's the opportunity to close the referral loop and let the medical home know when a need has actually been met and that services have been received. We're hoping that this will improve the quality of care and decrease utilization. All right, let's get into the nitty-gritty. So the data sources and variables that are available are really exciting. And like I said, they've been collected on a lot of patients for several years now. We're really interested in understanding, of course, which medical home a patient is from so that we know if they are in the prior to the intervention group or in the post-intervention group. And then we're really interested in being able to stratify on demographics that are available, the standard ones: age, gender, race, ethnicity, language preference. Social risk information that's available from the platform that Medical Home Network has called MHN Connect focuses on 5 main areas: things they need help getting, whether or not they have a friend or neighbor who can care for them, housing type, whether they're physically, emotionally safe, and whether or not they have transportation issues. In the future, we're really interested in understanding how they collect information about referral to community-based organizations. We should be able to see whether the community-based organization actually went into the system and viewed the patient there. We hope to know whether or not the community-based organization provided the service, whether the social risk factor was actually addressed and mitigated, and whether or not the response actually came back to the medical home. We are interested in comparing all that information to see if it makes any difference in some standard quality measures. Because the Medicaid Managed Care Organization is involved in the project, we're going to have access to all of the claims data across any setting of care, not just if it is at one of the medical homes in the study. So we want to look at things like 7 and 30-day follow-up visits after hospitalization, some general preventative screenings, and transition of care and continuity and coordination of care measures, in addition to the utilization measures of inpatient and emergency department utilization. And on the qualitative side, we're really interested in talking to patients and providers, both from the medical home side and the community-based organization side. So we have proposed a methodology where we will do paired interviews, but with 3 people. So they're triad interviews, if you will, where you've got one patient and the community-based organization provider and the medical home provider that cared for them. So we're proposing that we do 20 interviews of those 3 entities in groups, with the patient interview and the provider interview separate. We're interested in understanding how well the process is working for them, how well did it meet their needs, and what could we improve in the process to make it meet those needs better. Timeline. We're really interested in getting our advisory panel feedback before we go to the IRB submission. So that's our focus right now. We're developing interview protocols, and then our next steps will be to actually extract some data this summer and do some preliminary analysis based on what we have so far, so that when we get the final data next summer, we'll have a really good sense of how to work with all the data and be able to do that analysis pretty quickly. Additionally, we'll be doing the interviews for our participants in 2019. So right now we're in a very preliminary ramping up stage. And finally, let's talk a little bit about impacts. We're really excited about how our work may be able to inform our public policy efforts to continue to encourage the assessing and addressing of these social risk factors for patients. We think it's really interesting, especially in the context of value-based payment and health outcomes. And we hope that we will actually have some actionable information and some guidance that we can provide to health systems and communities on how they could best implement similar systems using the best practices that we find throughout this project. So that was a super fast overview. And I'm going to turn it over to Cheryl for the first commentary speaker.
Thank you, Keri. I appreciate that. Keri, is there a slide, or should I speak from this slide? Fantastic. So we are Medical Home Network, and just to tell a little bit more about who we are, we have been working for the past 8 years in Chicago with our provider partners, and we have 12 provider partners, a combination of hospital systems and federally qualified healthcare centers. And we have been working to collectively transform how healthcare is delivered with the goal of improving the health of our community. And we've been doing this collectively versus in silos. And we have been striving to be a regional leader for pop health management and the safety net. So as it relates to this project, as Keri said, our work has really been focused to create a model of care in which we push care management to the medical home or primary care practice level, and we empower our care teams to be able to manage the population throughout the continuum. In order to do that, we needed to connect our healthcare ecosystem. So we started by connecting the acute world to the medical homes, and in Chicago today, under county care, we are connected with 26 hospitals and 200 medical homes, and we capture now over 75% of inpatient and ER activity as it happens real time. But what we've also done is connect in context. We don't just connect real-time alerts, we connect and we put those alerts in the context of daily pharmacy data, claims data, care management data, and we enable a 360 view of the patient for all who have access to the system. And so now what we have been doing is connecting the subacute and the social service community, who are vital members who can help manage the population end to end. And Sana, I'm going to turn this over to my colleague Sana Sayal in a moment. She'll speak a little more in a little more detail about the actual project, but we are enabling communication between the care teams at the medical homes and the care teams at the social service agencies, and empowering them to also have some of the same views of the history of the patient to enable them to do better work at their sites and to enable seamless communication and exchange of information across the continuum to really begin to achieve that end-to-end management. One other thing I'd like to point out with social determinants, we've done a lot of work on social determinants. Our model, we focus on the medical, the behavioral, and the social. And we have been working to risk stratify our patient population using social determinants, and we have proved the predictive value of our stratification approach on prospective cost and utilization. So we know members that have social issues but no medical issues. They would have no medical issues, but they have social issues. In our population, they've shown a 60% increase in cost and 70% increase in inpatient utilization. So addressing social factors and connecting to the community is hugely vital to improving health, reducing costs, and enhancing care. So with that, I am going to turn it over, the next slide over to my colleague Sana Sayal, who is the project manager for Medical Home Network in this partnership.
Thanks, Cheryl. So as she mentioned, we are looking now to connect and go beyond the traditional medical ecosystem that is currently part of MHN Connect and really extend to those community social service agencies that have a shared goal of improving the health and well-being of these patients. And so this new module that we're building within MHN Connect is called Community Care to really support a bidirectional communication platform for those who are on the care team for the patient to speak with someone from a social service agency on the other end. And so the key here is that it's going beyond a traditional social service directory within the system to really connect a person on the medical side with those on the social service agency side to collaborate, share information, and improve quality of care for the patient. One other thing I'd note is that, we're not just building out this technology without any input. We are out in the field doing assessments with community agencies and with the medical homes on our system to really understand how can we incorporate this within your current workflows and support interventions that can be actionable and within the context of care. So the hope is that the building of this new module can really support the collaboration between these two disparate entities and really support the project that we're discussing today.
Wonderful. Thanks so much, Sana. Let's move on to our second commentary speaker, Sarah.
Hello, everyone. As I mentioned, Sarah Standish. I am the director of the evaluation department at HealthLeads, and HealthLeads is a nonprofit organization that envisions a healthcare system that addresses all patients' essential resource needs as a standard part of quality care. We can progress to the next slide. Thanks, Jen. And we are incredibly excited to be on the advisory team for this research activity, both because we've seen an increased demand for connectivity across the healthcare and social service systems, but also because we are interested in seeing how this demonstration can inform similar social health initiatives that we support across the country. I'm going to have you advance the slide. HealthLeads reaches its mission by partnering with healthcare organizations to integrate social needs into care delivery, and we do this by providing design support for social needs strategies, direct implementation support, as well as reach social needs technology, helping to connect social needs programs with resources in the community. I'm going to have you advance the slide. We work with a number of clinical partners across the country, as well as hundreds of learning partners as well. So where does HealthLeads usually start when we think about social needs intervention? And we usually start with the patient here with this care map, which I think illustrates well a lot of what Cheryl and Sana were describing in their intervention level connectivity model. Just provides a glimpse into how siloed each of these nodes are for patients, as well as the fact that patients largely carry the burden for identifying and managing information flow between nodes, and often don't have adequate technology or support in order to do that. We also know that patients who experience social needs have an even more complex map and often face additional barriers as they have nodes around legal support for unsafe housing, applications for food, engaging SNAP and WIC, utility support, coordination of transportation, and other things. And the result, we know patients with unmet social needs I think Cheryl stated this well, have higher cost, higher utilization of healthcare resources. They have unequitable health outcomes, and we also see the burden on the healthcare and social service system in the form of double documentation, lack of coordination, and asymmetry of information. So at Health Leads, we've noticed that there's been a real increase in market activity in this space. We've seen, from what we're tracking, around $40 million in additional investment that have gone to SDOH-specific technology platforms in the last 2 years. Some new technology partnerships, Epic and Aunt Bertha, C3 Evelyn and Healthify with the Mass ACO, and here with MHN, connections with county care. I've also seen some really interesting community-led mapping startups. One example here is Streetwise. And so clearly there is a need to address this connectivity pain point. And I think what's interesting about this demonstration and this research is that it is starting to answer the question not just whether connectivity is needed, but how to deploy it. And that's really where Health Leads focuses its work at the intervention level. And so we think a lot about what technology solutions could bridge that healthcare and community resource gap, and believe that connectivity and bridging is actually a critical part of the workflow. So here on the left, we have a sort of traditional hospital-based screen and refer intervention. What we see is that the critical node at the bottom, the resource referral and navigation activity, is one where, by the nature of that activity, we're actually branching into community engagement outside of the four walls of the hospital. And what we've seen in the work that we do is that there could be a number of really powerful implications from this research and from the demonstration of connectivity. At Health Leads, we know from our internal data that patients are 18 to 23% more likely to have at least one successful connection if they have a successful contact with a navigator or CDO in the first 2 weeks after screening. So having this type of automated referral system actually could have a significant implication for patients and their ability to connect successfully with resources. We also know that patient-reported outcomes are critical to monitoring day-to-day interventions, even when hard endpoints such as healthcare utilization might be the ultimate goal. And we've used this type of closed-the-loop referral data in order to drive quality improvement projects. And here I think there's an opportunity to think about the collaboration between the healthcare organizations and community organizations to have shared quality improvement goals that actually increase the success of connections and ultimately social health situations for patients. We also know that referral success and initial referral success can be a big barrier for patients. And we know that many referrals aren't successful from our work due to eligibility requirements, language limitations, hours, and location. And so this type of automated referral system can help, I think, more rapidly identify places where healthcare organizations and community organizations can communicate around what are those eligibility requirements, what are the ways to enable that referral to be more successful the first time. And it might also help us understand where there are gaps in the resource landscape. And I think implications around policy as well as structural barriers that collectively healthcare organizations and community organizations along with other partners can start to address. One example of this is we've actually seen requests for housing support double over the last 3 years at one of our clinics in Contra Costa County, and the wait list for Section 8 housing just reopened in Contra Costa after being closed since 2008. So here there's a clear gap between what's needed and what's available, and this information can be raised and shared at the county level in order to think about community resource planning. So those are just such a few ways that I think the outcomes and impact of this research have the potential to really inform not just the value of the connectivity, but how this connectivity can improve the success rate by which we connect patients to social needs and ultimately address their social health issues. And with that, I'm going to pass it back.
Great, Sarah, thanks so much. And I think we're ready for questions.
So thank you, Sarah and Cheryl, for your comments. And before we open the webinar to questions from the audience, which I'll be reading out, we do want to give you, Keri and Sarah, some time to just maybe respond to the commentaries or maybe add a little bit more to what you've presented. Or would you rather just go to the questions?
No, I would just say thank you very much to Cheryl and Sana and Sarah to really highlight why we think this work is going to be really exciting, and definitely I think our energy level is very high after doing this webinar and getting to share what we're planning with everybody. We're really excited to come back and tell you about our results soon.
All right, so we'll start opening it to questions now from our audience, and I just want to remind everyone that if you do have questions, just type them in the chat box and we'll try to get to them. If not, we'll forward those questions to the group later on, or even you can email us, and we'll also have the slides available too as well. So let's get to the first question, and this question is all the questions are open to both our presenters and commentary speakers, so please feel free to chime in at any time. Our first question is from Mary. Please define medical homes. Do you mean skilled nursing facilities or medical offices where people see their PCP?
Mary, that's such a great question. You've got two different perspectives around that on the phone, with NCQA having our primary care medical home designation, and also with Medical Home Network and having very specific concepts around what a medical home is. For the Illinois Managed Care Program, it is actually every patient has to be assigned to a medical home. That could be a doctor or it could be a federally qualified health center, but it's basically your primary care provider.
David has a question. How is community-based organizations defined? Could you give some examples, please?
Wonderful question on that. And actually, I wonder if Sana or Cheryl, you'd like to talk a little bit about how you guys are selecting your community-based organizations for this project?
Sure, Keri, I'm going to turn this over to Sana. We'd love to.
Yeah, so the community-based organizations that we are looking at are physically separate from the primary care medical home, and they offer services around behavioral health needs, substance use treatment facilities, housing support agencies. Those would be the top three that we're really started to engage now, and we're looking to expand also into food access and other areas of social services that could add value to the system. But again, this is about making actionable interventions in the context of all the care management work that's happening with the patient. So our goal is to make it a valuable connection for both the medical home and the community social service agency.
So David has a question. In the MHN Community Care Connect model, doesn't see any dental. Are dental providers included as a community-based organization? If not, do you examine connections to dental providers by medical homes?
So that's a great question. Through our Connect platform, we bring in plan data, and we are in the process of working to bring in dental data. You know, we understand the importance of understanding oral health and how it relates to medical health. But through our cloud, so to speak, that connects the ecosystem and puts all the relevant information in context for that 360 view, on our roadmap is bringing in data from the dental provider for the health plan and making that available to the care teams at the primary care practices.
Another question from David. How did you choose those specific quality measures? Was it based on the evidence of the relationship to social risk factors or some other process?
David, that is such a good question, and I was hoping someone would ask, because I'm definitely interested in all sorts of ideas from people on this particular point. We actually picked them based on availability of data. So we think that providing better social services to patients will have an impact certainly on utilization, which is why we chose emergency department and inpatient utilization. The rates right now are very high compared to national norms, so we think that we may be able to see actual impact even in the short 2-year time frame that this project is going to run out. As far as the quality measures, we had to think about what quality measures are out there that are existing that we're able to pull information from the sources that we have available. And we started with claims-based measures because we do have access to the claims. That if people have ideas about other quality measures they think would be particularly able to see an impact on in this time frame, we're really interested.
So Harold has a question. Have you considered linking or planning to link the data here with either criminal justice or 911 ambulance data to examine patterns there? If you wanted to, do you have human subjects data sharing agreements to do that?
I think that's a really interesting idea. We haven't. We're really focused on how that connectivity will impact folks' medical outcomes right now. But it might be something that we could explore in the future. I'd be interested in hearing more, Harold, about what you would envision for that kind of a project.
And I would just add, Keri, this is Sano. This is something from a data perspective that we've looked at in terms of can we connect with feeds from Cook County Jail to allow a care manager to know that the patient has been arrested or has been released to really support bringing that patient back into their primary care setting. We're working through some data discrepancies now, so it's something we're exploring. It's just tricky on the data side.
And to add, this is Cheryl, tricky on the rules, obviously. Release information is something that there's always a big lag on for a whole number of reasons and other things that the jail follows. People don't in advance know when they're going to be released. But it is something we're exploring. It's an excellent suggestion. And I'd echo what Keri said. We'd love to hear more of the thinking, Harold, on the applicability.
So Maricel has a question. How do community-based organizations connect with Community Care Connect? I guess more of a recap because I think you guys covered that.
Sure, no problem. So it's a web-based system, so they would be able to log in to access the information. We're looking into alerts that would help inform them on when to actually go in, since it is another system that they would use, along with mobile technology to support easier access to the system. So trying to make it easier on the community agency end to really get the information from the medical home.
And to complement what Sana said, it is a web-based system. We are looking at mobile, but it does work with mobile devices today. So if you have an iPad or any other type of portable device, the system is accessible on those devices.
Maricel also asked, have you considered working with early childhood Head Start programs which have medical home referral requirements?
So that's another great idea, and we have been working in concert with County Care, the health plan, to prioritize the connections and engagements, but that's certainly something that has been discussed. We are in phase 1 of our connectivity with the supportive housing, the behavioral health community, and some of the other areas that we have mutually decided have been prioritized. And equally as important, we have engaged partners in the community that are looking to connect and participate in this. But definitely something that's on the list. We have not really actively done anything to this point on that because of where we are in our phase 1 of implementation.
So keeping in mind that it is just started, Suzanne just asked if there have been any, I guess, baseline data or outcomes collected so far, or not yet?
Yeah, that's such a great question, Suzanne. This is Keri. One of the really interesting and strong points about this project that made it of interest to me is that historical data that Medical Home Network and county have been collecting for 3-4 years now. So we are able to see on some patients, their historical utilization patterns and what level of engagement and quality of care they've been having with their medical homes. So even though we're still in the process of putting together our quantitative and qualitative analysis final plans and submitting them to the IRB, that data collection is already happening and has been for quite some time. And as Cheryl and Sana and their team work to connect more organizations to the system, both on the community-based side and on the medical home side, they'll continue to move patients into that post-intervention phase, even though we're not actively doing anything yet. So I think that's one of the really interesting and unique aspects to this project.
So Luke is curious to find out if there were any legal institutional obstacles you may have encountered with implementing bidirectional sharing of behavioral health information, and how were you able to overcome some of these obstacles?
Luke, that is one of our favorite questions, but I'm going to let Cheryl answer it because she's a little bit closer to the ground in Illinois right now.
So the short answer is yes, Luke. I think with tenacity, we have figured out how to share Part 2 information in a compliant fashion. And this has really been the key to our success in connecting the ecosystem. So I think one of the obstacles we've encountered is not so much the organizations, because we've had this reviewed by council, multiple councils, and it's a bit of a process, so it's been a protracted process, but everybody agrees on the interpretation and the way in which we implement the compliant exchange. I think one of the issues has been in connecting the social service agencies, getting them to understand what can be shared back with the care teams in a compliant fashion. So sort of educating that there is a compliant manner in which we can exchange Part 2 information, and educating those agencies on what they can share back with the care teams. And I think that's been an education that Sana and team have been working on, and that's been one of our initial barriers that we are working to overcome. And I would also add, maybe going back to the question on baseline data, our approach to risk stratification has been we've quantified the predictive value of every one of the social determinants we measure on prospective cost and utilization. So we have great baseline data, for instance, on how needing help to getting food, clothing, and housing impacts prospective cost and utilization, and we'll be able, as Keri said, not only to use all the claims data, but really to look at all the baseline data that we've looked at on social determinants as well, and identify change in prospective cost and utilization, the impact of these connections on change in our prospective cost and utilization. So we've looked at this a lot of different ways and have a lot of different baselines.
All right, we have a lot of questions, and I'll try my best to get to as much of them, but I'll combine some that may have similar themes to the questions. One is from Suzanne and Ruth. They talk about or ask about how do you plan to manage communication with those clients who are homeless and have no phone. And Ruth asks more details maybe about the structure of the communication to support collaboration across settings, again, through meetings, phone frequency, and how do you foster collaboration point of referral.
That's a really great question. Yeah, Cheryl, I think it's best answered by you.
So on the collaboration front, our model is such that we have care teams of licensed and unlicensed professionals working at the primary care practices or medical homes, and they serve as the control tower operator for care management across the continuum for our patients. And so we have our model set up to where they are delegated for care management, and then we also have the connectivity set up across the ecosystem to support this collaboration. So even if we have different care managers or a behavioral health care manager engaging the patient in one way, through this exchange, we're creating a unified care plan and a unified approach to care management. So everybody knows their roles, and we have one person in charge making sure that everything is organized, and we reduce poly-management syndrome.
And I would just add to Cheryl's point, in addition to initiation from the care team at the primary care setting, there's plenty of patients who more often go see their behavioral health provider in the community and are more established with that agency than they are with their medical home. And so the initiation can also happen on that end, where a case manager knows that this patient needs primary care services and can ping that care manager to let them know and connect on next steps. So initiation could happen on both sides.
That's great. I think that answers Christina's question about, too, of how the platform was designed for multi-service agency and connectivity between multiple CBO service providers. Mary and Katie has a question that's related to having the model in rural settings, or has there been a similar model successful in small and rural counties that
Sarah,
you know of?
Do you want to talk about that? Sarah, do you want to talk about that from Health Lead's perspective?
So we have, so at Health Leads, we have worked in a few rural settings, thinking about a high utilizer project in Southern California that utilized largely telephonic outreach. But I would say the majority of relationships that we have across the country are in urban areas. And I'd be curious whether others have good examples of rural health initiatives that bridge this gap successfully.
Okay. So Claudia asks, are HIEs involved in any of these referral networks? And if so, how also are there any networks or providers using Bertha or Healthify? And if so, how do these services interface, if at all, with the HIEs? Multiple layers and many players really make things difficult for providers.
Sana and Cheryl, do you want to talk a little bit about the Illinois landscape with the HIE, as well as how you've connected to some of the EHRs for the medical homes? And then the final part there, I think it'd be really interesting to talk about what you've done so far with social services directories and where you hope to go.
Sure, Keri. So in Illinois, unfortunately, we have not had an HIE that has launched. So we are the closest thing to an HIE that we have in Illinois, and we have connected directly with the hospitals in the Chicago region to exchange real-time alerts, and then we get our data from the payer, Cook County Care, on the claims and RX, and then we put that in the context of care management data from our own system, and again, work to create this 360 view. So that's one thing. We have used Purple Binder, and we integrate it into our care management platform. We don't use it as a standalone. What's key for us is that everything's part of a continuum and works to support workflows and prioritizes tasks. So everything has to be in one system and support a workflow. And so we use it as a lookup tool for referrals, but Community Connect, what we discussed today, is really a wraparound to that and takes it to a whole new level, because we're enabling care teams at the social agencies to see the full 360 view of the patient and to enable bidirectional communication with the control tower operators at the medical homes. In terms of EHR integration, that is something that we've done, and we continue to work to foster tighter integration with our EHRs. Again, the goal is to to make sure that the right information is in the right place and that it pops up at the right part of the workflow. So a care plan, for instance, we are working on our next interoperability project, so care plans pop up in the EHR at the right point in the workflow where they need to be seen. So I'm not sure if that completely answers the question, but interoperability is key, and making sure the right information is in the right place is also key.
All right. You know, there's still so many questions, and I think your presentation and the commentary speakers have really generated a lot of interest in this study. And so I do apologize for those we're not able to get to your questions, but we will make sure to forward them to the research team, and we'll let them get in touch with you guys too as well. So with that, I would like to thank you, Sarah, Keri, Cheryl, Sana, and Sarah for that excellent presentation. We do look forward to learning more as your project moves forward. And we want to thank again everyone for joining us today for today's Research in Progress webinar. And we do invite you to take a look at upcoming webinars, and also today's presentation, the slides and the presentation itself is available for download at our Systems for Action website. So once again, thank you for joining us, and we wish you all a very good day. Thank you so much.